All right, let's get right into it. If you're a pathology trainee, you already know that pediatric renal biopsies are just different. The stakes are incredibly high, the diagnoses can be really tricky, and your report, it literally guides the entire treatment for a child. So today, we're going to do a practical walkthrough of the CAP protocol. This is your essential guide for nailing these cases every time.
And look, when I say this is the guide, I really mean it. This isn't just a list of suggestions. The CAP protocol is the official standard of care in North America. Following this, make sure you're giving the best care possible and that your reports are clear, complete, and exactly what the clinical team needs. So here's what we're covering. First, we'll talk about why this protocol is so important. Then we'll get into the nitty-gritty of handling the biopsy itself. From there, we'll hit the main tumor types you've got to know. Then we'll decode anaplasia, which is the single most important prognostic feature. And finally, we'll wrap up with the molecular studies you need to have in your back pocket.
Okay, Section 1, why does this matter so much? Well, in Pediatric Path, you are not just putting a name on a slide. You are fundamentally setting the course for a child's entire life. A diagnosis of Wilms tumor versus, say, a rhabdoid tumor? That means completely different chemotherapy, completely different prognosis. Your accuracy from the get-go is everything.
And get this is a direct quote from the protocol itself. I mean, it's a pretty honest admission that these tumors are just plain hard. They can look like each other, and on a tiny little biopsy, sampling error is a huge risk. This is exactly why a standardized step-by-step approach isn't just a nice idea. It is absolutely critical for patient safety.
So that brings us to handling the actual biopsy. You know, before you even think about putting a slide on the microscope stage, the choices made right there at the grossing bench are setting you up for success or for failure. Getting this part right is the foundation for the entire diagnosis.
And the protocol is super clear on two main things here. First, just avoid frozen sections. The reason is simple. The false positive rate is way too high. So unless the surgeon absolutely needs an answer to decide their next move in the OR, it's best to wait. And second, and this is so important for modern pathology, always snap freeze some viable tumor, at least a gram. Oh, and don't forget to freeze a bit of normal kidney too. That's your perfect control for molecular studies down the road.
All right, the specimen's handled, it's in process. Now for the fun part, building that differential diagnosis. When it comes to pediatric renal tumors, there are really four main players you have to have on your radar. So we're going to walk through each one. First up, the most common one, Wilms tumor. You know, the classic look you're taught is that triphasic pattern. You've got the small blue blastemal cells, the spindly stroma, and little tubules from the epithelium. Now, the biggest challenge, especially on a biopsy, is telling a Wilms tumor from a nephrogenic rest. They can look identical. Here's a pro tip from the protocol, though. Wilms tumors often have a fibrous pseudocapsule around them, which nephrogenic rests usually lack.
Next up is congenital mesoblastic nephroma, or CMN. This is a tumor you see in infants, and it really comes in two main flavors. You've got the classic type, which is made of these really bland, kind of sweeping spindle cells. Then you have the cellular type, which is way more packed in, more dense, with a lot more mitosis. And telling them apart is critical, because almost all the recurrences happen with the cellular type.
Okay, now for the one we call the great mimicker, clear cell sarcoma of the kidney. This thing is a nightmare, diagnostically speaking, because its cells can look like almost anything else. But there is one huge clue to look for, its vascular pattern. You've got to look for this fine, delicate network of branching vessels, we call them arborizing, that snake between the tumor cells. If you spot that pattern, CCSK needs to jump right to the top of your list.
And that brings us to our fourth and final big one, and it's the most aggressive of the bunch, rhabdoid tumor of the kidney. This is another one you see in infants, but man, the prognosis is so much worse. For this one, it is all about the cytology. You're hunting for those classic rhabdoid cells, big cells that aren't sticking together, with wide-open vesicular nuclei, a single, prominent, almost cherry-red nucleolus, and these pink, globular blobs in the cytoplasm. Seeing those features is a major red flag.
Okay, so let's put it all together with a quick cheat sheet. This is super high yield. For Wilms, think triphasic. And for molecular, look for LOH at 1P and 16Q. For CMN, remember that cellular type has the ETV6-NTRK3 fusion. For our great mimicker, CCSK, it's all about those arborizing vessels and the BCOR duplications. And finally, for rhabdoid tumor, you're looking for those rhabdoid cells and that classic loss of INI1.
Now we've got the main tumor types down, but let's zoom in on Wilms tumor specifically because once you've made that diagnosis, your next job is maybe even more important. You have to assess for anaplasia. Its presence is the single most powerful prognostic factor there is, and it completely changes how the patient is treated.
So it all boils down to this one critical question. Is the anaplasia you're seeing focal or is it diffuse? And this is not a judgment call. The CAP protocol lays out incredibly strict location-based criteria that you have to follow to the letter.
To call anaplasia focal, every single one of these criteria on the left has to be met. It has to be stuck in just one or two distinct spots, be totally surrounded by non-anaplastic tumor, and you can't have any anaplasia in blood vessels or outside the kidney. If you break even one of those rules, it automatically becomes diffuse. So if you see it outside the kidney, diffuse. If it fails any of these focal criteria, diffuse. You can see why careful sampling is so important.
And this leads to an absolutely critical, high-yield rule you have to burn into your brain. If you find anaplasia in a random biopsy, it is always considered diffuse. Why? Well, think about it. A random biopsy, by definition, can't meet those strict location requirements for being focal. You have no idea if it's a tiny spot or the tip of a giant iceberg. This simple rule has massive implications for the patient's prognosis.
All right, last section. Let's talk about our molecular toolkit. Ancillary studies are just essential these days. They help us confirm tough diagnoses, they give us crucial prognostic info, and sometimes they even point to new therapies.
So for Wilms tumor, the key molecular markers are all about prognosis. If you find a combined loss of heterozygosity, or LOH, at chromosomes 1p and 16q, that's an adverse sign, and it means the patient's therapy is going to get ramped up. A gain of 1q is also bad news, and no real surprise here, TP53 mutations are found in most of the Wilms tumors that show anaplasia. Now for congenital mesoblastic nephroma, the molecular findings line up perfectly with what you see under the scope. That cellular subtype, the one that looks a lot like infantile fibrosarcoma, it has the exact same ETV6 NTRK3 gene fusion. The more chill, classic subtype, on the other hand, is driven by EGFR activating mutations. It's a really neat correlation.
And for our great mimicker, clear cell sarcoma, molecular testing can be an absolute lifesaver. The most common thing you'll find is something called a BCOR, internal tandem duplication. A smaller group will have a YWA, NUT2B fusion. Finding one of these can be the final piece of the puzzle that lets you confidently sign out a really difficult case.
And finally, for rhabdoid tumor, the hallmark finding is a mutation or deletion of the SMRCB1 gene, which you probably know as INI1. And the beautiful part here is that we have an immunohistochemical stain for this. These tumors lose the nuclear staining for the INI1 protein, which is a fantastic diagnostic clue. Just remember the protocol's warning. A few other rare tumors can lose INI1 as well, so context is key.
So, you did it. You followed the protocol, you used your molecular tools, and you've made the diagnosis. But wait, what's next? Your job isn't quite finished. A diagnosis like Wilms tumor should be a trigger for you to think beyond the microscope. You have to ask, could this child have an underlying predisposition syndrome like Beckwith-Wiedemann or Denis-Drash? Your diagnosis is just one, albeit critical, piece of a much bigger clinical picture, one that's going to involve genetic counseling and long-term care. It's a powerful reminder of the incredible impact our work has.